I've just started recording, Julie.
Okay, over to you, Rahul. All yours. Thank you.
Hello, everyone. A very warm welcome to the Royal Hospital for Women Newborn Care Seminars 2021. Notices on our talks are available on our social media groups on WhatsApp, WeChat, Telegram, and Signal. You can email Prof. Julie, Uri, or myself if you want to join these social media groups. There are some Zoom etiquette before we begin today's presentation. Please ensure you're muted at all times, except, of course, to ask your question or comment. We have about 10 to 15 minutes at the end of the talk for Q&A. Please use the reaction buttons to raise your hand or use the chat box by writing your name so we know you wish to ask a question, or type a question in the chat box and we'll try to get to as many of them as possible. The talk from today will be available, of course, with the speaker's permission on our university website. And over to you, Julie.
Thank you very much, Rahul. My name is Julie Uri. I'm one of the neonatologists from the Royal Hospital for Women, and thank you very much for joining us today. It's a great pleasure and an honor to have Dr. Harvey Sarnat present to us today. I was very fortunate to meet up with him last year in Calgary before lockdown, and I used the opportunity to ask him to speak today. So Dr. Sarnat probably needs no introduction, but I'll do the spiel anyway. So Dr. Sarnat is a professor of pediatrics, pathology, and clinical neurosciences at the University of Calgary. He says he's retired, but he still has a microscope and an office in the university. His remarkable career began in 1963, where he got a Bachelor of Science at the University of Illinois, specializing in neurobiological studies. He then completed his medical training and then a specialty in child and adult neurology at the University of Virginia under Dr. Fritz Dreyfus. So he officially retired at 2013. I won't say his age, but he continued to work full-time, chiefly in his very productive neurodevelopmental, neuroanatomical, and neuropathological research programs at the Alberta Children's Hospital. He is one of the 8 permanent members of the International League Against Epilepsy Commission on Neuropathology, the only one from North America. He has too many publications to mention, but his lasting legacy, which you're all aware, is the Sarnat Score, which is the most widely used clinical assessment tool for infants at risk of neonatal encephalopathy. The Sarnat Score is also the most commonly used to decide whether a baby receives one of the most important interventions to decrease the risk of death and disability in neonatal encephalopathy, therapeutic hypothermia. The paper that he did reporting the Sarnat Score is considered one of the 4 most important papers in neonatology by the Neonatal Society of Britain. So without further ado, maybe I'll just pass the baton over to Dr. Sarnat now to tell us what those babies in the 1970s has taught us how to manage hypoxic ischemic encephalopathy today. Thank you, Dr. Sarnat.
Thank you very much, Julie. I want to thank Dr. Julie for inviting me to give this conference today. And it's especially meaningful for me in Australia, because I spent a year and a half in Perth at the Princess Margaret Hospital for Children and the King Edward Hospital for Women, and enjoyed very much that experience, and Been back to Australia several times since that time, and so this is something very special for me. I need the icon for share screen. I don't see one here, so I can upload my presentation. Here we go. Okay. Let me bring it up. There it is. Can everybody see it?
Yeah, we can.
Okay, very well. Thank you. Well, it is a great honor to give this conference. I wish I could be doing it in person instead of virtually, but I understand. Well, in 1976, we published this. Really, it was just a small pilot study of 21 babies, and at the time, we didn't think that it was going to be anything that would persist for more than a year or so. As just a pilot study. But actually, it has turned, sort of had a life of its own, because it was sort of the first study of its type, and the methodology was very clinically oriented, so that it could be done in any hospital, and it has been repeated and confirmed by numerous other authors in other centers, so that it has some validity, and it seems to work, and we continue to use it, and it still seems to work. But almost half a century later, we wanted to reconsider whether maybe there is some items that should be updated, because of all that's been learned in the last half century, and the new technology and treatment modalities, such as hypothermic, therapeutic hypothermia, that didn't exist in the time that the study was done. So we'd like to talk about some of these things, and under learning objectives here, we've put the reference to the original paper, and then also to one which was just published recently last year, suggesting some ideas for perhaps improving it or updating it at least. And so really the learning objectives are to understand the original scale and its application to neonates with perinatal hypoxic ischemic and other progressive encephalopathies. And you notice that if you read the paper, the original one, the 21 babies all had well-documented hypoxic ischemic encephalopathy, were born at term. And we avoided putting that specific diagnosis in the title of the article. Because we considered that perhaps the scale might be useful in other kinds of neonatal encephalopathies other than hypoxic ischemic. And indeed, this has been the case. So that the title of the article talks about neonatal encephalopathy, but it doesn't include the title hypoxic ischemic, although clearly in the article that's what we're talking about, at least for the cohort that we studied. And then the other aspect that I'd like to discuss this morning is to understand muscle tone, postures, and movements in both normal and encephalopathic neonates. Because it's one thing to be able to make the observations of abnormal muscle postures, abnormal muscle tone and postures, for example, and to correlate them with certain aspects of encephalopathy, and that's very useful. But if you take it a step further to understanding why the postures do occur this way, and what do they mean in terms of the neuroanatomy and neurophysiology, then you get into an area where you really understand pathogenesis, and it makes it much more meaningful and to go in depth into that, so that the postures are not just simply observations that you can record, but rather with some deeper meaning about what is actually happening in the neonatal brain. And we hope to show you some examples of that. And so this slide just shows the original published staging, 3 stages, and the revision that we're suggesting isn't really all that different. One of the disappointments over these years has been that in the original, we had put a lot of emphasis on autonomic function, such things as pupillary size that's not influenced by narcotics or drugs that might alter the pupillary size, intermittent bradycardias, increased peristalsis from increased parasympathetic tone to the myenteric plexus. And somehow the autonomic functions haven't received as much attention as at least I think they merit. And so in our newer scheme, we're trying to emphasize that again so that people will pay more attention to it. And we're also introducing some things that we didn't do in the first, which was things like olfactory reflexes, which we will go into a little bit later in this talk. So what are the things that have changed in the last 45 years to suggest that there's a need for an update in the grading scale, since it served so well in so many centers all these years? First of all, we have a lot more experience with the grading scale throughout the world in multiple centers. And there are advances in EEG technology. In the original study, we were using paper recordings of 8-channel EEGs. Actually, I did the EEGs myself because I didn't have any grant and I didn't have technicians, so I used to come in at night and take the EEG machine out of the EEG lab and bring it to the nursery. And in the NICU, I would connect the electrodes and measure impedances, measure heads, and do the recording, and then I would report them. So that, but now we have electronic video monitoring, and we have amplitude integrated EEG and other things that didn't exist at that time. Neuroimaging didn't exist in 1976. The closest thing to neuroimaging that we had was the pneumoencephalogram, which was a highly invasive study, and it only showed you the contours of the ventricles. And you had arteriography, of course, to show you the blood vessels, and you could diagnose a subdural hematoma that way. But we didn't have anything, we didn't even have CT, much less MRI. And there's also been a lot of advances in neuropathology because immunocytochemistry was very almost non-existent in 1976. And so everything was based on hematoxylin and eosin stains for histology. And That's a stain that was invented 100 years ago in 1920. And it shows you a lot of things, but with specific markers for showing synaptogenesis and for showing specific types of neurons, GABAergic and glutamatergic neurons, and many other features, we can certainly be much more precise now in studying tissues than was possible at that time. And as I say, there's a much better understanding of the pathophysiology of abnormal posturing, dyskinesias, the generation of seizures, and correlation with developmental processes. And therapeutic hypothermia, of course, has made a big difference in treatment and outcomes. And then we have to see how can this scale be adapted for that. So these are the changes in the proposed grading scale that I've already mentioned many of these things. I won't repeat them, but there are some other techniques that can now be applied, like near infrared spectroscopy, which can tell you about functional tissue oxygen extraction that varies during sleep-wake cycling and is altered in hypoxic ischemic encephalopathy. Transfontanellar Doppler ultrasonography is useful for cerebral blood flow velocity, resistance index, and it's not part of the revised clinical criteria, but it's a supplementary study. And we have many metabolic biomarkers now in blood and urine that didn't exist 50 years ago. So I'd like now to talk a little bit about the pathophysiology that produces the abnormal posturing that we see in the neonate with encephalopathy. The corticospinal tract or pyramidal tract is a large descending pathway from the cortex to the spinal cord. And it is the common pathway for influences by the cerebellar system. There are no direct cerebellospinal pathway. And it's also the common pathway for influences from the deep telencephalic nuclei, the basal ganglia, caudate nucleus, putamen, and globus pallidus, because there are no descending pathways to the spinal cord from any of those nuclei. They have to ascend to the cortex and influence, invoke their influence via the corticospinal tract. But the corticospinal tract has only a limited function in the newborn. And we've known since the time of Ramon y Cajal in the late 19th century and early 20th century that there are multiple small bulbospinal pathways that originate in the brainstem and that can descend to the spinal cord, and they can have function in terms of influencing muscle tone and strength. And examples of these pathways would include the rubrospinal tract, the vestibulospinal tract, the olivospinal tract, the reticulospinal tract, and several tectospinal tract. There are several of them. And if you take all of these pathways, you can group them together as medial and lateral subcortical spinal pathways. And that's what Kuipers and Lawrence did in some studies, some very elegant studies they did in neonatal monkeys to make destructive and stimulating lesions in these pathways and in the nuclei that are from which they originate, in order to observe clinically what they did to muscle tone. And that has given us a great deal of insight into the pathophysiology of posturing in hypoxic ischemic encephalopathy in humans. In the term neonate, there is an equilibrium, an antagonism or balance between the medial subcorticospinal pathway and the corticospinal tract. The corticospinal tract is functional in the newborn, but it's not anatomically mature. And by mature, I'm defining that as the terminal axonal ramifications for innervation and myelination. And these aspects are not complete until 2 years of age postnatally. And so the function of the corticospinal tract is different in the newborn than it is at maturity, and it definitely plays a role. So if we divide, or as Kuipers and Lawrence did, if we divide the pathways into the medial and lateral subcorticospinal pathways, the medial subcorticospinal pathways that you see here illustrated in this drawing are antagonistic to the corticospinal tract in terms of they influence axial and appendicular postures and muscle tone. And there is an equilibrium that exists between these two pathways. And because in hypoxic ischemic encephalopathy, the cerebral cortex is impaired much earlier and more severely than the brainstem is. The brainstem is more resistant to ischemia, to hypoxia. You remove the corticospinal tract influence, and you see what happens when you lose the equilibrium, and the medial subcorticospinal pathway is the one that is showing the greatest influence. The lateral subcorticospinal pathway is of much less significance. It causes weak axial flexion and doesn't really affect distal joints. The medial subcorticospinal pathway causes strong axial extension and strong distal flexion. The corticospinal does just the opposite. It causes flexion of axial and proximal joints and distal extension of the fingers and abduction of the thumbs. And so this is how you have these antagonism. And this is the original reference of Lawrence and Kuipers from 1968. And then there's another article here that I wrote talking about these things much more recently. So now let's take a look at how these things might actually be expressed in living infants that we examine. So on the left here is a photograph of a 9-month-old infant who was born at term with severe acute asphyxia during delivery, and he has the opisthotonos posturing. On the right is a term, you see the extension of the spine and also extension of the hips. And if you look at his hands, this infant has a little cotton wad in his hand because he has this strong distal flexion, and this is to protect him from breaking down his own skin by this strong fisting of his hand. The infant on the right is a term neonate, well, also a different baby who has acute asphyxia during delivery, and you see that there is strong adduction of the thumb and flexion of the fingers over the thumb, and there's also flexion of the wrist. So here we have distal flexion, and we have extension of the axial muscles of the spine. And if we go back, what did we say? The medial subcorticospinal pathway causes strong axial extension and strong distal flexion. And the corticospinal tract antagonizes it. So what we are seeing in these infants is medial subcorticospinal pathways from the brainstem that are causing these postures because they are no longer balanced, and the equilibrium is lost between these pathways and the corticospinal tract, which is not functional on a temporary basis, hopefully, because the cortex has been impaired by the ischemia. Here we see a premature infant who shows abduction of the hips instead of the extension. Remember, in the previous one, we showed the extension of the hips with opisthotonos. Now we're seeing abduction. And the reason there's this difference with a premature infant has less to do with the nervous system innervation than it does with the development of the hip joint. And so it just makes it for less resistance for the premature infant to abduct his hips rather than to extend them. And you notice also in this even in this premature infant that there's strong distal flexion. Adduction of the thumb and flexion of the fingers come from the same pool of motor neurons in the spinal cord, whereas adduction of the thumb and extension of the fingers also come from the same different pool of motor neurons in the ventral horns of the spinal cord. And even at the present time, these were studies that were done in 1968 by Kuipers and Lawrence, but even at the present time, there's continuing discovery and greater appreciation of the importance of brainstem synaptic circuitry and the bulbospinal tracts for postnatal motor control. Here's an article from Switzerland from Nature, just published a couple of months ago, showing a functional map for diverse forelimb actions within brainstem circuitry. Exactly what we're talking about, the subcorticospinal pathways. Now, another aspect that we see are dyskinesias. And in the here we are. It was shown by Albrecht Piper. He was an early pediatric neurologist who published this work in 1961. And it's really a landmark work. It was published in German, of course, and actually he worked in Leipzig, which was at that time part of East Germany before Germany was reunited. It was translated to English 2 years later. And what he described was that between 26 and 32 weeks gestation, normal premature infants exhibit dystonic movements of the shoulders and hips and athertotic postures of distal joints. The pictures I show you here of the hand and foot of infants, of premature infants, these are photographs that are taken from Piper's original 1961 book. And you can see these abnormal postures. By 32 weeks, we no longer see these kinds of postures. So why would they occur? It's been shown actually that beginning as early as 15 weeks gestation by real-time ultrasound, that these postures also occur in infants in utero, normal infants. This baby obviously is not 15 weeks gestation. It's on the cover of Alessandra Piontelli's famous book, but this was published in 2010. She showed that with real-time ultrasound, the same thing occurred that Piper had described in premature infants after delivery in 1961. So there's an explanation for that, and this is some of the work that we've done in terms of looking at the normal development of the corpus striatum. Corpus striatum is the caudate nucleus and putamen together, which are really the same nucleus. They're just separated by the anterior limb of the internal capsule. And this is an immunoreactivity for synaptophysin, which is a glycoprotein that forms the structure. It contributes. It's one of the most important ones in the structure of synaptic vesicles, and it's transported by exoplasmic transport because it's synthesized in the neuron cell body in the perinuclear area and transported to the terminal axon. And so it's a good marker in tissue for the sequence of synaptogenesis, both normal and abnormal. And we do these studies in infants who, despite the best of clinical care, have not survived. I just want to mention that these tissues and these fetuses that we study are always treated with the greatest of respect in our laboratory, and we feel very privileged that we have the opportunity to be able to study this tissue. So at 13 weeks gestation, you can see that there is no brown staining synaptophysin reactivity. Here's the white areas that you see here in the upper left-hand panel are fibers of the corticospinal tract within the internal capsule, and the little dark nuclei that you see are those of the caudate nucleus and of the putamen. By 21 weeks, we see a pattern of patchiness in both of these areas. You see that there are patches of synapses in some areas and not in others. By 26 weeks, you still see patchiness, but the areas that show no synaptic formation in 21 weeks now are filled in with some reactivity, but not as strong as some other areas. And in the term neonate, it's uniform throughout the corpus striatum. The little white areas you see are little intrinsic fiber bundles. They're called the pencil bundles of Wilson. And of course, the anterior limb of the internal capsule, the larger white area that wouldn't have any synapse activity. So we see a development of a patchy pattern. And this patchy pattern, which is immature, corresponds temporally very well to the observations of Piper and that have been confirmed by other investigators of the dyskinesias and athetotic movements that we see in premature infants. It's because of the sequence of synaptogenesis in the corpus striatum. Now, we can also look at the EEG, and we can say, what does the EEG in the term neonate with hypoxic ischemic encephalopathy, why does it resemble the normal maturing EEG of the preterm neonate? So here you can see the semi-periodic pattern of sort of burst suppression pattern of high voltage sharp wave activity, and then you see it falls off, and then you have almost isoelectric, almost no activity or very low voltage activity in between for the next burst of activity. And in the full term neonate, you don't see this semi-periodic pattern any longer. What you see is continuous activity, except in sleep. And the reason you see this pattern is that these bursts of activity are times when there is direct cortical stimulation from the thalamus. The thalamocortical projections are discharging, and the thalamus acts as a pacemaker, so that every few seconds, the thalamus discharges to the cortex, and it stimulates the synaptic activity of the few synapses that are formed already in this premature infant at 26 weeks. And the flatter periods in between the bursts of activity represent the intrinsic cortical rhythms without thalamic stimulation directly. And since there are so few synapses formed in the cortex, you don't really have much EEG activity. And here we have another example EEG of a 3-day-old infant born at 29 weeks gestation. Did not have encephalopathy, but you can see this semi-periodic pattern, the same thing that we just talked about. And here is an infant born at term, and he has a very similar semi-periodic pattern of bursts of activity with interperiodic, very low voltage activity that closely resembles what we see in the normal premature infant. So let's now look at the synaptogenesis of the cerebral fetal cortex. We saw the basal ganglia, we saw the corpus striatum, and so at 19 weeks gestation, here's the cortical plate at the upper left-hand panel, and you can see that there's a little bit of synaptic activity in the deep part of the molecular zone, and there is no synaptic reactivity here in the cortical plate itself. At 26 weeks gestation, we see much stronger activity in the molecular zone, and we see stronger activity in the deep part of the cerebral cortex, but the superficial layer, layer 2 especially, shows no synapse formation yet. These lines, these radial lines that you see of synaptic activity, this is synaptophysin molecules within the thalamocortical projections to the cortex. By 33 weeks, we see that there is synaptic reactivity in all parts of the cortex, but it is much stronger in the deeper layers and in the deep part of the molecular layer than it is in the more superficial layers. And in a term infant, it's uniformly strong throughout the cortex. And so what's the reason for similar EEG activity in normal preterm infants and in term neonates with hypoxic ischemic encephalopathy? The difference, the reason is that it doesn't make any difference to the recording electrodes in the scalp whether synapses have not yet formed or whether the synapses are non-functional. And what happens in hypoxic ischemic encephalopathy is that there is a depletion of the stores of neurotransmitter within the cortical neurons, and there's impairment of resynthesis of those transmitters because the whole metabolic mechanism of the neuron is impaired. And so it takes time for the neuron to recover and to start synthesizing synapses. Hello? Yes? Okay. Again. And so this is the reason that you have the similar kind of semi-periodic pattern in small premature infants, especially extremely preterm infants, and in full-term infants who have hypoxic ischemic encephalopathy. It's because of lack of a deficiency of synaptic function within the cortex, whether the synapses have not yet formed because the infant is too young, or because the synapses are anatomically formed, but they're non-functional because the neurotransmitter is depleted. Now, turning to another aspect, olfactory reflexes. Neonates show constant responses to olfactory stimuli from about 30 weeks gestation. And actually, it's been shown that the fetus also responds to aromatic molecules dissolved in the amniotic fluid. And they get there because these are transplacental strong odors that are carried there by maternal diet. If the mother is eating something with a strong odor, such as garlic, onions, spices, curries, then it crosses the placenta, it enters the amniotic fluid, and the fetus can respond to it. And so we can see this in fetal, we can even see differential responses in fetuses after 30 weeks gestation, and we see it in preterm infants postnatally at that time. And so if you want to test olfactory reflexes, then you need to use an aromatic substance, not an irritant. If you use an irritant, such as ammonia, for example, it will stimulate the pain endings of the fifth nerve, which also live in the nose. And that's a much stronger stimulus than it is the olfactory stimulus. Even though ammonia has a very distinctive pungent odor that wouldn't be confused with anything else, you could identify its smell as ammonia and wouldn't think it's anything else. But it's also stimulating pain endings. So what we use is peppermint oil. And if you just take a little small plastic or glass tube from the laboratory, and you put a portion of a cotton ball in the tube and a few drops of peppermint oil in that, there's your olfactory tester, and it'll be good for months or sometimes even years without having to, it doesn't dry out and lose its odor. To examine the neonate, the baby should not be in quiet sleep for this examination. He should be awake. And the reflex, which we described actually in 1978, is that neonates, about 2/3 of the time, the infant begins to either suck or extend the tongue or move the lips or show some kind of mouthing movements. And another third of the time, there's a sort of alerting or a withdrawal response, facial grimacing or wiping the arm across the face that tell you that the baby has responded. You may have to test the baby several times to be certain of the responses, and the responses also are impaired if the baby has a lot of nasogastric tubing and or has a nasal obstruction. Of course, then that's going to interfere with the perception at the olfactory epithelium. Responses are diminished in hypoxic ischemic encephalopathy, and we're trying to quantitate that a little bit more now as an additional criterion for the scale. And so here's a baby, here's the little test tube. You can see the baby is being tested. You don't want to touch the baby with the tube because that's a tactile stimulus, but you just want him to feel it, and the eyes are open, the baby is not asleep, and the baby will start to suck. The cranial nerve 1 is seldom examined in the newborn or even in older children, and nevertheless, it conveys information about a unique part of the brain that is not tested by any other part of the neurological examination. It's very easy to do. It doesn't require any special equipment except this little tube that you can keep with you in your bag or in your purse, and it may contribute to understanding. Also, it may be a part of the new criteria. And actually, it's been shown in adults who have impaired consciousness from various types of injury, including traumatic injuries, that they have impairment of olfaction. And we know that in congenital infections and other types of infections, including COVID, in fact, that there is impairment of olfaction as one of the clinical signs. And that probably has more to do with the involvement of the olfactory epithelium than it does with the olfactory bulb. But nevertheless, there's impaired olfaction. Now, what about abrupt transitions at birth? There are many systems in the body that undergo rather abrupt transitions at the time of delivery. The lungs, the pulmonary system is probably the most important example in this regard, because you suddenly have expansion of the lungs and the breathing of air, which didn't occur until the baby was delivered. The cardiovascular system also undergoes very drastic change just at the time of birth. There's loss of placental circulation, and there's increased pulmonary circulation and closure of the ductus arteriosus. The GI tract, you're introducing milk into the GI tract for the first time in the baby's life. And even the musculoskeletal system, the baby's limbs were flexed during fetal life in the fetal postures. And for the first time after delivery, the baby's able to extend his or her extremities. Now, the central nervous system doesn't really exhibit any abrupt changes during transition from prenatal to postnatal life, but rather just a continuation of the developmental processes. However, only recently it's been shown that there are some subtle but important changes demonstrated that indicate that the time of birth indeed initiates some acute changes in the nervous system. And one of the ones that has been demonstrated is a peptide system in the brainstem that is activated at birth and is protective for postnatal breathing because of its effects on the respiratory centers in the brainstem, which are the nucleus solitarius and the pre-Botzinger nucleus mainly. So now we're beginning to understand that there are some acute changes in the nervous system that never were understood previously. This is an article from this year from Nature. Does hypoxic ischemic encephalopathy affect cerebral blood flow velocity and resistance to activation of cerebral blood flow? Doppler ultrasonography, which is easy to apply at the bedside, even very sick babies that don't have to be moved. You don't have to take them to a MRI machine or anything. The transcranial Doppler can show changes in hypoxic ischemic encephalopathy that may be useful in terms of both diagnosis and prognosis. Now, the autoregulation of cerebral blood flow really develops quite late during fetal development. It occurs in the second half of the third trimester. And there are two reasons why it may be late. First, there may be immature neural mechanisms of innervation of intracerebral arterioles. And secondly, because the formation of the smooth muscular wall around the intracerebral arterioles it occurs very late. And so because the arteriole is really the end organ of intracerebral autonomic innervation, if the muscular wall is not yet well formed, then it can't respond to innervation, even though the neural mechanism may be mature enough to do so. And this is also something that we're in the process of investigating to try to separate those two out and find out which is the more important. But the important clinical observation is that autoregulation of cerebral blood flow may be temporarily impaired in hypoxic ischemic encephalopathy. And this has an important implication in terms of the ability of the infant to recover and to for neurons to be able to recover rather than die. Another aspect that can be studied is by near infrared spectroscopy monitoring in preterm and term neonates that also can assess cerebral autoregulation and enable intervention even in some cases. And it also can detect functional tissue which may respond differently during the sleep-wake cycling. So these are some other newer aspects that are being investigated in a variety of centers, but may prove to be very important in terms of both diagnosis and prognosis. Therapeutic potentials. Therapeutic hypothermia, of course, is the only really effective therapeutic intervention right now to protect the brain from further damage. And it temporarily inhibits neuroblast migration, synaptogenesis, neuronal loss, and microglial activation. But the grading scale can be used before and after the therapeutic hypothermia is performed, but it's not really recommended right now during it because it's difficult to interpret in the active impairment of cerebral function. That may change with more study. Experimental use of stem cell infusions is another promising potential therapeutic measure, and if it can be combined with therapeutic hypothermia. And the best source of the stem cells is actually autologous placental progenitor cells from the infant's own placenta, where there is no possibility of any rejection. And actually, this is being done by Dr. Elliot Teo in Brisbane in piglets. He shows increased neurons, less microglial activation, and improved behavioral scores after treatment. So this is still in investigative stages of development, but may prove to be another treatment that might be offered in future. Xenon inhalation combined with hypothermia is another technique that is recommended, well, not recommended, but is being studied and seems to show some promise. I don't have any personal experience with that, but it's in the literature. And then galectin-3 is an important molecule in cell extracellular matrix signaling, and it's upgraded 24 to 72 hours after an hypoxic ischemic insult. And so inhibition of GAL3 provides histological protection of cortical neurons, at least in rodents, and whether it does in humans is yet to be studied, but at least in mice, it seems to work. Near infrared spectroscopy, we've talked about that, varies during sleep-wake cycling. This is not therapeutic so much as it is diagnostic. And here's just to show how in the neonatal hypoxic ischemic model, it's quite different from the adult stroke model, showing differences in galectin-3. So this is something else so there's a number of means of potential treatments besides the therapeutic hypothermia, which seem to be promising, and some of them may turn out to be useful, others may not be so useful, but at least it's something that we need to take into consideration, and there may be other techniques developed in the future which really we don't even know about at this time. So I thank you very much for your attention, and I hope my take-home message would be really to try to look at the pathophysiology of why you see clinical observations of postures and tone and breathing patterns and We didn't talk so much about seizures, but that would be another aspect. Try to understand what the basic neuroanatomical and neurophysiological basis for it is, not just try to remember the clinical observation by itself. Thank you.
Thank you so much, Dr. Sarnat. That was wonderful. We've got a question on the chat pane. I had a problem getting my chat pane for a long time. So a question from Srini from our unit. He asked if there's a stage where we can recommend therapeutic hypothermia for mild encephalopathy in clinical practice, because it seems to be becoming a therapeutic creep. Would you like to comment on that?
Is there a time when we can recommend therapeutic hypothermia? Is that the question?
Yes.
Well, I think this is one of the most important issues, as in terms of using therapeutic hypothermia, is when do you apply it, and to which babies do you apply it? Who are the candidates for it? And these are, I think, these are issues which are foremost in investigation of therapeutic hypothermia. I don't have a strong comment to make about that, because I'm not, that's not a study that I'm engaged in myself, and my experience with therapeutic hypothermia is a bit limited. I see babies who are in the NICU who are in which this technique is being used, and I think it's a very valuable and legitimate technique to use. But I can't answer the question of how early it should be used, or the selection of babies. In general, of course, we feel that the earlier that intervention occurs with almost any treatment, the better it is. But with therapeutic hypothermia, that may not necessarily be the case.
That's right. Would you mind if I asked Dr. Shankaran to unmute and reveal herself for her opinion on this? And before we move on to Sita, there's a thank you from the neonatologist at the Royal Prince Alfred Hospital in Sydney. Dr. Shankaran, would you like to comment on that question? She has unmuted herself. Sita, can you hear me? So while Sita is trying to unmute herself, we might move on to the next question for Dr. Sarnat. There's a question from AK. I'm sorry, I don't know your full name. She asked, or he or she asked, what is the best time to do the score? The first hour, 2 to 3, or up to 6 hours, Dr. Sarnat? Oh, answer. Okay. I answer. Dr. Sarnat, could you comment on that?
I have to unmute. I'm sorry.
So, yeah, that's right. It's pretty. Yeah.
That's a very good question. And in general, we saw with the original study, and we continue to see that the most severe changes with hypoxic ischemic encephalopathy actually are not immediately at birth, but on the second day. And the reason is probably that the neurons that are still functional have transmitter and are able to use them, but they then become depleted. We talked about that earlier. They become depleted and no longer can function as neurons because they can't communicate without transmitter. And so this takes about 24 hours. And so on the second day is when you're going to see the worst picture. And that also is true if you look at the electroencephalogram. It's going to look worse on the second day than it will on the first day. I think that it's useful to repeat the exam on the 5th to 7th day, as well as the EEG on the 5th to 7th day, because infants who continue to show persistent abnormalities after that time, after a week, or who show persistent EEG abnormalities, generally have a more guarded prognosis. It's not that they all will have a bad prognosis. Some of them may still recover, but the ones who recover well within 5 days, especially, or 7 days, are those who you can anticipate will have a good prognosis for neurological development later. Of course, using the scale, the Sarnat scale is not something that's invasive, And so it can be done daily if you have the time and interest in doing it. You can't do it too often because it's not invasive and it gives no risk. I don't know if that answers the question.
Yeah, the trouble is with a lot of us, we are time limited now by the 6-hour window for therapeutic hypothermia.
Yes.
So yeah.
Well, in that case, you try to do it as close to the time when you would start the therapeutic hypothermia as possible. I mean, if you have a 6-hour limit, then probably at 5 hours, I would say, would be the a good time to do it. But you can do it multiple times. Really, it's not something that's going to pose any risk to the baby.
Thank you. I've got 2 questions on the chat pane, but I can't seem to access my chat pane at the moment. So in the meantime, while I'm trying to work that out, is Dr. Shankaran able to unmute herself? She seems to have disappeared. Shruti, we can't find her again. Rahul, can you see what's on the chat pane for me?
Yes, yes, Julie.
Thank you.
So there's a comment made from Dr. Helen Liley. So it says, we collected modified Sarnat scores daily while on treatment for the pain study, some missing data for later days. So should we be able to report when the study follow-up is completed, the prediction of outcomes by scores at a different time point? So if Dr. Helen Liley would like to unmute herself.
Just wanted to add thanks to everybody who contributed in any way to that study. Hopefully it will give us a very good set of data to confirm what Dr. Sarnat has said in a contemporary group of babies. Dr. Sarnat, this was a study of just over 300 babies that we have recruited into a randomized trial of either therapeutic hypothermia alone or therapeutic hypothermia with high-dose erythropoietin.
Thanks very much. That's very useful. I should have mentioned erythropoietin. I didn't, but I certainly recognize that. That's another aspect.
Could I just comment also that our impression is, although again we'll be able to analyze this better using study data, is that cooling itself modifies the scores.
I don't think it modifies the scores. I think that I think the basic scheme is still the basic scheme.
Well, I think the effect of with the impression that we have is that the effect of cooling is to improve the encephalopathy from quite early on, so that the scores on, the scores on day 2 or 3 or 4 are not as severe as if you hadn't called the baby.
Well, I think that's a good observation, and I think that's
Yeah.
valid, very valid. And as I said, you can repeat the scoring any number of times. You can do it shortly after birth to start out as a baseline, but I think the most severe changes you're going to see are going to be at 24 hours. The worst scores, I should say.
Helen, are you frozen or?
No, I'm here.
Oh, good.
Sorry, I just turned off the video and audio again because I thought
the perils of Zoom. Yes. Okay. So maybe an examination with a Sarnat score at 5 days is more predictive of outcomes than an MRI.
Well, we may actually be in a position to answer that, although with complete respect for the points, the very important points that Dr. Sarnat has made, is that our modified version of the Sarnat score is similar to the ones that have been used in some of the calling trials, and the US HEAL trial, and I think Dr. Sarnat's right that to be really comprehensive, we'd have all the autonomic variables as well, and we don't. So we do have some other information about autonomic stability, but the modified version of the score that we've been using has been focused on the elements that are the behavioural responses and tone and things, so, or the reflex responses and tone and things. So it's not really a complete assessment of, and complete, and I'd certainly pay tribute to the importance of the full score. But just for reasons of pragmatism, we haven't got all the items.
Yeah, thank you. I think that, these are not one or the other. I think we haven't included imaging, for example, as part of the scoring, because it's a separate thing, but there's no reason why the clinical scoring and imaging and EEG data and biomarkers and other things that might be available can't all be integrated, and putting them all together, you end up with a more precise picture of what the prognosis might be. So
I think that's a really good point, and we have a PhD student starting work at the moment on analysing the AEGs, the MRIs, for the babies in the study and the general movements assessments that we obtained for babies in the study, but there's probably at least one more PhD in it. So if anybody knows of a good potential student, please send them my way.
Great ad, Helen. Thank you. Well, we really look forward to your studies results. I can see Sita desperately trying to get, she's trying to unmute herself. For a few minutes left. Sita, would you like to comment? No, we're having a bad tech day, Dr. Sarnat. Yeah, so that was wonderful. We have no more questions on the chat pane and we are out of time. If that's okay with you, we'll upload the recording onto the website and to our social media pages. And also, if it's possible for me to share your email in case there are other questions from the participants.